Hello. Hi, everyone. Welcome back. I hope you all had a good lunch break or coffee break. I'm pleased to be moderating our afternoon session. It was terrific to see so many of the Zoom breakout rooms with the different languages. I hope you enjoyed that. And thank you to all of the volunteers who made that happen. I just wanted to make one announcement. If anyone is active on social media, I see some tweets from our conference. Please use our hashtag FMDSA 2021. It is now my absolute pleasure to introduce our next speaker. Dr. Olin was mentioning that sometimes he feels like I'm his little sister, and this would be my academic little sister. Very pleased to introduce Dr. Esther Kim, Associate Professor of Medicine and Director of the Arteriopathy Clinic at Vanderbilt University in Nashville, Tennessee, here in the USA. And she's going to talk to us about SCAD and its relation to FMD. Esther, good afternoon, good morning, welcome.
Hello, good morning here in Nashville, Tennessee. Dr. Gornick, so lovely to see you, and I wish I could see everyone's lovely faces. Being at this meeting every year is always so inspirational to me, so I can't wait to be together again in one room, but until then, I'm happy to be here. Thank you so much, Pam and Jeff, also for inviting me and including me. So I'm going to go ahead and share my screen. Can everyone see this? Not yet.
We can. Esther, we see your screen.
Okay, great. All right, so Pam has tasked me with speaking on this topic, spontaneous coronary artery dissection and its relation to fibromuscular dysplasia. Frequently asked questions and an update on the iSCAD registry. So we will start off with the basics. What is SCAD? SCAD stands for spontaneous coronary artery dissection. And the medical definition is that it is a non-traumatic, meaning that the injury did not occur as a result of a trauma of some sort. Non-iatrogenic, meaning that it wasn't a result of an injury from a medical procedure, such as a wire going down the coronary artery. And it's a separation of the coronary arterial wall by intramural hemorrhage, creating a false lumen with or without an intimal tear. So I'll kind of walk through that definition a little bit. Any artery has three distinct layers. There is an intima, which is sort of like the brains of your artery. It helps function by receiving different signals that are related to inflammation and clotting. There's the media, which is sort of the workhorse of the artery. It helps to regulate blood pressure. It can do something called vasoconstriction, where the artery clamps down when it needs to, or vasodilate when the artery dilates when it needs to. And then the adventitia is the connective tissue that holds everything together and keeps the arteries in place in your body. So a dissection occurs when there is a separation of these arterial layers. And you can see in this schematic here that there is actually bleeding that has occurred on the inside of the artery between the intimal layer and the adventitial layer in the media layer. And so when there is no tear or rent in that intimal layer of the artery, you can see that there is compression of this true lumen where the blood flow normally would go down. And there's compression causing what we call a stenosis, or narrowing in the artery, which can lead to decreased blood flow to the end organ. Sometimes there is no rent in the artery layer called the intima, but sometimes there is a rent or a tear in that layer. And in this case, this is what we call an intimal tear. And you can see a true lumen and a false lumen, because now blood flow can go into the false lumen and the true lumen. And you can see on an angiogram that there may be two areas where the blood flow can go down to the end organ. Now, how is a SCAD heart attack different from a regular heart attack? Good question. So I'd like to bring your attention first to this part of the slide. Now, the heart is just a muscle, and the muscle requires oxygen, and oxygen is carried by blood, and blood is carried in the arteries. And so you need an open artery in order to supply blood to the muscle of the heart. When there is lack of blood flow because of a blockage, Then when your muscle needs more oxygen because it's pumping harder and faster for one reason or another, i.e. times of stress or exercise, and there is a blockage in the artery, the blood flow is no longer adequate to supply the need of that muscle for oxygen. And so here we have several situations in which a blockage can occur. One of them is what we call atherosclerotic plaque. This comes from the usual cardiovascular risk factors, hypertension, hyperlipidemia, family history, smoking, etc. And over time, I should say also the Western diet, over time, you can see that cholesterol can deposit and build on the arteries and develop a blockage. And when the blockage gets to be about 70% or more, it can actually cause something like a heart attack in times of stress. So here is an oxygen supply demand imbalance because of a fixed blockage from cholesterol plaque. There are also cases where there is dynamic narrowing, such as in vasospasm, when that medial layer of the heart muscle is acting sort of on its own and not in response to something that is normal. So it will vasoconstrict or squeeze down on the artery temporarily, but there is no fixed blockage because over time that artery will relax again. And so if you were to do an angiogram when a patient doesn't have any pain in the heart, you may not see any blockage at all. And then here we have coronary dissection, where you can see that intramural hematoma and the blockage that it causes. And here's a cross-sectional view of that. And sometimes in any one of us, even if we have an open artery, if we were to exercise very vigorously or have very, very high blood pressures, there's nothing wrong with the artery. It's just that the demand is much more than the oxygen supply of the normal heart can provide. Now, these are what's called type 2 myocardial infarctions, and coronary dissection is considered in this bucket. A type 1 myocardial infarction is the type of heart attack that everyone is familiar with and for which we have many different treatments. And this is really caused by cholesterol plaque rupture. So here is this cholesterol plaque, and some cholesterol plaque is stable. It's calcified, it's glued down to the artery. Some cholesterol plaque is unstable, and instead of being like a hard rock in the arteries, it's actually squishy and gelatinous and liquefied in the center. And when there is the right stressor that occurs inside the body, such as inflammation, the top layer of that plaque can actually rupture, and the blood, your body tries to wall that off by forming a blood clot. But what happens when that blood clot forms is that you can have actually a complete blockage in the artery or a partial blockage, and this can cause a heart attack because now there is not enough blood flow going down the arteries. Okay, so in this context, this is type 1 myocardial infarction, cholesterol plaque rupture, and here is SCAD right here, non-atherosclerotic coronary artery dissection. Well, why is this important? Well, as I just demonstrated to you, those heart attacks are not the same. And should heart attacks that occur for different reasons be treated the same? So for instance, balloons and stents that were developed for atherosclerotic type 1 myocardial infarction are excellent. They have great outcomes, and patients develop immediate relief, and the stents stay open for a long time. There's millions of patients enrolled in worldwide studies historically that have shown that stents in acute myocardial infarction, the earlier the better in some types of heart attacks, proven. But in SCAD, we try to avoid stents unless the blockage in the artery is life-threatening and your life is in danger. And if you need a stent or a bypass surgery, these are also efficacious in SCAD as well. We also know that blood thinners and antiplatelet agents are also beneficial in type 1 myocardial infarction with atherosclerotic plaque rupture. But are these helpful or harmful in SCAD? And this is still being worked out. We know that statin medications save lives after heart attack from type 1 myocardial infarction. And it's unknown really whether or not statins are beneficial, harmful, or neutral. And currently the practice by consensus is that unless a patient with SCAD has another indication for a statin medication, i.e. hypercholesterolemia or plaque somewhere else, generally we don't keep patients on statin medications because they've had a SCAD heart attack alone. Now, who gets a SCAD heart attack? As mentioned previously, amazing, wonderful registries going on all over the world to study this disorder. These are laudable studies. I'm just going to show you an example of 3 large registries that have published their data. One from Canada by Dr. Saul, one from the US using the Mayo Clinic registry, and one in Spain. And you can see some remarkable similarities. So we all see that the mean age, the average age, is late 40s to early 50s, primarily women in all of these registries, primarily white. Body mass index was not calculated in 2 of these registries, but in the Canadian study, about average. A normal BMI is that which is 25 or less. And about 20 to 35% of patients with hyperlipidemia, about 30 to 40% of patients with hypertension, and somewhere about a quarter of patients with smoking, depending on the country that you are coming from. I think what we should notice here is that the rates of cardiovascular risk factors are lower than what we would expect with patients with traditional myocardial infarction. Patients are generally older, generally male, and generally have higher prevalence of these cardiovascular risk factors. So if you had to sum it up, who gets SCAD? The average person would be the middle-aged white woman with few traditional cardiovascular risk factors. And they may look like some of these patients here. And here's Catherine Leon, the founder of SCAD Alliance, who also helped to found the iSCAD Registry, which I'll be talking about. Catherine had a peripartum SCAD, and certainly she and the other patients listed here do not look like patients who look like they should have had heart attack. Now, how common is SCAD? SCAD is rather uncommon. If you were to look at all heart attacks that occur, about 1 to 4% of all heart attacks is from spontaneous coronary artery dissection. But if you were to narrow that number down to women who were less than the age of 50, about a third of those heart attacks are from spontaneous coronary artery dissection. It used to be that we were taught that the most common place that we would see a spontaneous coronary artery dissection was in the context of pregnancy. And sure enough, SCAD does comprise a significant proportion of pregnancy-related heart attack. But if you were to look at the entire population of patients with SCAD, the pregnancy-associated SCAD is actually rather less common. And unlike traditional coronary artery disease, where you may have anginal symptoms that lead to a stress test and a positive stress test, and then a cardiac cath that leads to a heart stent, patients with SCAD generally present with heart attack. And what I mean by that is patients will present with acute chest pain, EKG changes, and a positive troponin. A troponin is the cardiac muscle that we can see when we do a blood draw. And when we see muscle in the blood, it tells us that there is some myocardial injury that is happening or a heart attack that is happening. Thankfully, things like sudden cardiac death and dangerous arrhythmias and shock occur less commonly as a presentation of SCAD. How does SCAD relate to FMD? Very good question. This is a figure from a review article that Dr. Ganesh and I and other authors wrote and was published earlier this year. And what we did is we looked at the prevalence of various risk factors amongst people who have fibromuscular dysplasia and those who have spontaneous coronary artery dissection. And the bars represent the ranges. And so you can see that similar to fibromuscular dysplasia, spontaneous coronary artery dissection, high prevalence of women, also high prevalence of European ancestry, although the SCAD registries do tend to have a little bit more diversity in the publications. We see that patients with fibromuscular dysplasia have much higher prevalence of hypertension compared to the cohorts that have been studied in spontaneous coronary artery dissection. There may be some slight differences in smoking, some slight differences in hyperlipidemia, but low prevalence of diabetes in both groups, and age is almost identical. And so how do we break this down further into raw data? Again, the registries here, I show the large one from Canada and the large one from the United States. We see if we add the FMD registry in here, that the age is very similar, the sex is very similar, and the race is very similar. And here is a picture of a group of lovely SCAD patients from a SCAD symposium we had at Vanderbilt. And here are a group of patients from the FMDSA site. And really, is FMD and SCAD, are they sisters or cousins? And I think that pictures are worth 1,000 words. And so there may indeed be a link. Well, if there is a link, how often do SCAD and FMD occur together? So this table comes from a review article that was published in 2020. And what we did in this review article was looked at the prevalence of vascular abnormalities and fibromuscular dysplasia in SCAD cohorts that had more than 100 patients enrolled. So really, this was the world literature up to that time describing screening for extracoronary vascular abnormalities. And certainly, we didn't have the benefit of the European data, but I think that also adds some additional data. And what you can see is that really, in these cohort studies, there is large percentage of incomplete screening, meaning that not all patients who presented with SCAD had head to pelvis imaging to look for extravascular abnormalities. But keeping that caveat in mind, we see that the percentage of FMD on average is about 50 to 60%. And if you were to look at the non-FMD extracoronary vascular abnormalities, and this would include aneurysm and dissection, we would see that the numbers are not small. And certainly the rates of brain aneurysm are also not small and larger than what you would expect in a general population of women who are of this age. So what is the SCAD-FMD relationship? I've been showing this slide for a long time, for several years. And consistently, the studies, it really depends on the modality of screening, whether you use an ultrasound, a CT scan, an MRI scan, or catheter-based angiography. The SCAD prevalence is anywhere from 25 to FMD prevalence among patients with SCAD. So if you have a SCAD heart attack and your doctor orders a study to look for FMD, you'll find it a quarter of the time to almost 90% of the time. So a very wide range. According to the US FMD registry, if we look specifically at the variable of SCAD, it's only about 2.7%, but these are older data. And these data, as Dr. Olin mentioned earlier, are actively being updated, and probably this number will go up as the awareness of the interaction between SCAD and FMD goes up, and also the diagnostic ability of physicians to diagnose SCAD goes up. And what do I take away from this? Well, I take away that SCAD is the presenting sign of FMD in some patients, but probably not all patients. What else is associated with SCAD heart attacks besides FMD? This is another illustration from the same review article in 2020. And what you see here is a depiction or a cartoon of the various types of spontaneous coronary artery dissection. The type 1 spontaneous coronary artery dissection is that which causes that intimal flap. It's that rent in the innermost artery layer. And you can see what we call a train tracking when you do an angiogram. And these two types here are the intramural hematoma type. And these intramural hematoma type coronary dissections were underdiagnosed for a very, very long time until seminal work by Dr. Saul and her group in Vancouver really helped us to define and understand that this unusual appearance really is intramural hematoma in a SCAD variant. So if we look at the associated conditions and inciting factors. So we have SCAD in the middle, and I think most people are familiar with Venn diagrams. We see that fibromuscular dysplasia and associated arteriopathies, that there is significant overlap between these entities. But there are other entities such as connective tissue disorders and inherited arteriopathy, such as Marfan syndrome or vascular EDS. There is also overlap with hypertension in patients with SCAD, significantly more hypertension and FMD. So this Venn diagram probably should include much more FMD here. Certainly pregnancy is a risk factor. And other would be things like idiopathic, meaning we really couldn't identify something else. Perhaps inflammatory disorders such as autoimmune are in here. Perhaps thyroid disease is thrown in here as well. These are all conditions that really require more study. And then the outside ring is inciting factors. Do sex hormones play a role? Does intense exercise play a role? How about emotional stress? What about medications and drugs or activities that require you to hold your breath and bear down or very heavy lifting? And understanding this diagram here and better refining this diagram should be a key research priority. So there were two major consensus statements which were really published at the same time and thankfully say very much the same thing. The European Society of Cardiology and the American Heart Association both came out with consensus documents to help patients and their physicians understand how to think about spontaneous coronary artery dissection, all the way from what does it look like on angiography to what should we be thinking about after SCAD? How do we treat the whole patient and not just the heart attack? And I really liked what the European study said here, that prospective studies, including ultimately randomized studies, assessing the best medical therapy, e.g. the role and duration of antiplatelet therapy such as aspirin and Plavix, use of beta blockers and other secondary prevention drugs, as well as the optimal coronary intervention strategies such as stenting or balloon or nothing, are urgently needed. And in the US AHA scientific statement under key research priorities and key questions in SCAD was listed, what is the proportionate contribution of FMD and other systemic arteriopathies to the development and recurrence of SCAD? And this is a very important question which we hope to further define through the US FMD registry and the iSCAD registry as well. So on that note, the iSCAD registry was developed to develop and maintain an independent quality data repository to advance the pace and depth of SCAD research around the world toward the common goals of improving patient diagnosis and outcomes and accelerating scientific discovery. The leadership of the registry is shown here. I am the chair of the steering committee. Catherine Leon, who is the co-founder of SCAD Alliance and the chair of its board, is a steering committee member, along with Dr. Melissa Wood, who is a cardiologist at Mass General Hospital in Boston, Dr. Sahar Naderi, who is a cardiologist at Kaiser in California, and Dr. Mike Gibson, who is the director of our coordinating center called Perfuse. And similar to the US FMD registry, we have registry centers that are all around the country who have institutional IRB, as well as a data use agreement with the coordinating center Perfuse. And SCAD Alliance is the sponsor of this study. And under the direction of Dr. Gibson and his Perfuse staff, the data meets up at BIDMC in Boston. And through the publications committee and the steering committee, publications and presentations will be the output of this study. The iSCAD registry first enrolled its first patient on March 8th, 2019. And I'm very happy to tell you that as of December 1st, 2021, we have 833 patients enrolled in 19 enrolling sites across the country, with 2 sites currently onboarding. And these are the current onboarding site, currently enrolling sites, and very, very proud that we have sites from west to east coast, as well as from north to south. And we are continuing to build because we recognize that SCAD is not just a condition of people who can go to registry centers and fly and be able to afford that. And so we really want to increase the diversity of patients, not just by race and by sex, but also by socioeconomic status. And so we are making a concerted effort to include sites that also serve populations who may not be able to travel to get their medical care. The key elements of the iSCAD registry include patient and investigator engagement, dedicated sites. Similar to the FMDSA registry, the sites actually do not receive funding to enroll patients or to complete the case report forms. And so, as Dr. Gornick said, this is also a labor of love. One of the key aspects of the iSCAD registry is that the SCAD heart attack must be adjudicated. And so Dr. Gibson, who has over 30 years of clinical research leadership and also running large clinical trials in coronary artery disease, also serves as the angiographic core lab to adjudicate all coronary angiograms. One of the things that we're very proud of as the iSCAD registry is patient engagement. And from the very beginning, with the inclusion of Catherine Leon on the steering committee, we asked patients, what are your big questions? And they actually helped to develop the case report forms, as well as participating in many of our webinars that we did during this pandemic. And if you want more information, you can look at our YouTube channel. And working on our first paper, even working on the first paper, we asked patients, what are your ideas about SCAD? What is important to you? And we think that the patient voice is the most important thing in this. And we want to answer a question for patients. It's important for doctors to understand what's going on, but patients have their questions that need to be answered just as importantly. I'm very happy to announce that we submitted 4 abstracts to the American College of Cardiology meeting. We'll be hearing whether or not these were accepted, hopefully shortly. But to give you a sense of the types of research that we are doing, one abstract was on reproductive health features associated with SCAD. Another one was the prevalence of potential triggers and underlying medical conditions in SCAD. The third was migraine headaches in patients with SCAD. And then lastly, extracoronary vascular abnormalities in patients with SCAD. So hopefully at the next patient meeting, I'd be able to show the results of these studies with you. So in summary, I hope that it's clear that SCAD is different from usual heart attacks. And FMD is detected in about 50% of patients, but really the prevalence depends on the modality of screening. And the iSCAD registry is a patient and physician-initiated clinical study which aims to help answer the pressing questions related to SCAD. Thank you very much.
All right, Dr. Kim, that was phenomenal as always. And we have lots of questions. We're a little short on time, so we're going to do this very rapid fire. Okay, so take that sip of water because here we go. Okay, can you comment on how SCAD is diagnosed, both in the setting of acute heart attack and if people with FMD should be screened for SCAD?
Really excellent question. SCAD is usually diagnosed in the throes of a heart attack. Very uncommon that a patient would have classic angina, chest pain when you walk that goes away with rest, and then has a stress test and then a cath, like I said. And so SCAD is a diagnosis that's angiographically made. And so if you present with a heart attack to a hospital and you get a coronary angiogram, that's how it's diagnosed. A lot of times now that SCAD is kind of on people's radars, patients may also receive a coronary CTA, and we can sometimes see SCAD if it's in the larger arteries through a coronary CTA. Unfortunately, there is not a good way to screen who is at risk for SCAD. And so if you have fibromuscular dysplasia and I did a coronary CTA or a CAT scan of your heart arteries, Just because I don't see any dissection there doesn't mean that you're not at risk for having a dissection. And certainly I wouldn't want to do a coronary angiogram unless there was a reason to do it, such as having an acute heart attack, because a coronary angiogram has risks associated with it because it's an invasive procedure.
All right. Patient asked, she had a SCAD and was told her artery was damaged. She's wondering, what do we know about the natural history? Does that heal? Will my artery always be damaged?
Oh, great question, and one that I did not cover. But yes, Dr. Saw did some amazing work in her SCAD registry, and she looked at patients who had repeat coronary angiograms for one reason or another. And what she found is that 90% or so of patients within 6 weeks had some evidence of vessel healing, meaning that the blockage caused by the dissection was actually improved by 6 weeks. And in some patients who've had a SCAD, they may have an angiogram years later, and I will compare the two angiograms side by side and not even be able to tell they had a SCAD. So yes, the natural healing, the angiographic diagnosis, or the angiographic healing of this, we do see with time.
All right, this is a great question. Is there anything, a patient's asking, anything I can do with my diet or lifestyle to either to prevent a SCAD or prevent another SCAD?
Fantastic question. Unfortunately, there is nothing from a dietary perspective that we know has been proven to work. I wish there was something that we could eat or drink or take to strengthen arteries. I think that would be such an amazing thing. We don't have that yet. But I would say controlling blood pressure is really important. We know from at least a couple studies that hypertension, high blood pressure, is associated with recurrence of SCAD and also just with dissections in general. So really work with your doctor to get your blood pressure under control. And that translates to adopting things like a low salt diet. We know for overall cardiovascular health, the Mediterranean diet has been shown to be good. And I mention this because patients are in their late 40s, early 50s. And at that age, you're just at risk for developing atherosclerotic disease as well. And so I think starting young at the Mediterranean diet, controlling blood pressure is very important.
All right. What do you define as head to pelvis image specifically?
Yes. So that really means that we're looking at all the arteries starting from the head and going all the way down to the top of the legs. And in my practice, I have a protocol where patients can get a CT scan from head to pelvis in one go. Other places, such as in Europe, they may use an MRI or an MRA to look at the arteries. Other places may look at ultrasound, etc. Certainly ultrasound can't look at the brain, but head to pelvis imaging really means dedicated imaging of each arterial bed to look not just for fibromuscular dysplasia, but things like brain aneurysm, splenic aneurysm, things that we may need to monitor going forward.
There was a question, is there any case where you can say a SCAD was triggered with certainty by stress?
What a great question. And I don't know that we have an answer to that. All I can tell you is that there are patients who develop SCAD in stressful situations. I had a patient who had a SCAD yelling at customer service on the phone, and patients who've had SCAD after the death of a loved one. But then there are patients who have SCAD sitting at church, who are just listening to the sermon. Maybe it was a very good sermon and exciting, I don't know. But there are patients who develop their SCAD and they can't identify a trigger. And so that's why, that Venn diagram and those, precipitating factors don't all point towards the SCAD in everybody. I think it's a different situation. What we're probably learning is that there's probably a genetic predisposition of some sort, and then some environmental trigger, whether that be hypertension or undue stress or hormones or something else.
And folks, we won't be able to get to all of the SCAD questions, but hold them for our panel discussion at the end of the day. But to end, Esther, classic question we get, it's tough to answer. For someone who's had a SCAD or someone worried about their risk of SCAD, what do you say about exercise and activities?
I think I've evolved in the way that I think about exercise too. I think that what my patients have taught me is that after SCAD, anxiety and depression are real. And when your doctor tells you you can't lift more than 10 pounds and you live in fear, you gain weight, you become depressed, and all of a sudden your quality of life is horrible and terrible. And so I think doctors, because we don't want anything to happen to you, we tell you not to do things. We don't have data for that. And so what I say to patients is exercise in moderation. Do not exercise to exhaustion. You can run your 5K, don't win it, is what Dr. Melissa Wood always says. And I think that's a great way to visualize that we want you to be active. We want you to be happy and healthy, but take precautions, because life after SCAD, you have to come to realize, is going to be different, but it doesn't have to stink. You can still have a good life.
Well, Dr. Kim, I think on that positive note that definitely our patients can have terrific lives even after SCAD. We want to thank you for your outstanding presentation. Hopefully we'll see you a little bit later. And happy holidays. You got a lot of cheer back there.
Thank you, Dr. Gornick. Thanks, everyone.
All right. It is now my pleasure to introduce our next speaker.